Imagine that you are the person who was carrying that large window pane that now lies in shattered shards around your feet. You look at the pieces in dismay because you realize that you can no longer put these pieces back to their former smooth, translucent self. But suddenly, a smile lightens your face. You smile because you see forms of mosaic art that these pieces of glass can form. You see that because now you're looking at the spaces between the pieces of glass. I'm Dr. Frank Douglas, the CEO and founder of Safe Haven Dialogues. I'm also the host of the Reframe for Resilience podcast. In this podcast, we engage guests and discuss situations where they use different approaches to solve problems. In short, where they reframe the problem. And we also try to understand how those approaches helped with resilience. Welcome. This is Dr. Frank Douglas, the CEO of Safe Haven Dialogues and your host of Reframe for Resilience. Today, we're introducing another format of Reframe for Resilience. We are introducing case discussions. And to help me today in this premiere version of case discussions is Ms. Deanna Darlington. She is the CEO of Links to Equity, former director for many years of patient advocacy at Amgen. She is a longtime colleague of mine, and I'm just so delighted that she's participating with us. The format will be, I will pretend that I am the aggrieved person in the case. I will read the case, after which I will ask Ms. Darlington some questions. And I will end by giving the call to action, if you like, for the audience. So let's get started. I'd like to share with you the environment in which I work. I'm Dr. JD, a Black attending physician, and I work in the emergency department of a large hospital. Helping Hands Hospital is a busy inner city hospital whose patient population is mostly poor, blue-collar, working-class minorities. The hospital is staffed by residents with attending physicians who are a phone call away, except in the emergency department, where attending physicians supervise residents on site 24 hours a day. Attending physicians determine which patients get admitted to the hospital from the emergency department. I'm the only Black attending physician in the department. Within the emergency department, research is considered important, but is not necessary. Here's my situation. I evaluated a high-risk Hispanic patient with chest pain and determined the patient should be admitted to the hospital. I informed Dr. H, a third-year resident on the medicine service, that the patient had been admitted to the hospital and he should do the onboarding interview. Dr. H came down to the emergency department, saw the patient, and discharged the patient from the hospital. When I noticed that the patient was getting dressed, I attempted to approach the patient at bedside. I was physically blocked by Dr. H, who prevented me from talking to my patient. Additionally, Dr. H grabbed my arm in an aggressive manner to prevent me from moving forward. I wrote an incident report and submitted it to the hospital administrator and sent a copy to my boss. The next day, my boss, the chairman of my department, met with me to discuss the incident. He suggested that I attend a meeting with Dr. H and the hospital psychiatrist. I declined. Over the ensuing 2 to 3 weeks, my boss arranged a meeting with Dr. H and the head of his department. At the meeting, Dr. H's department head told me that he had spoken to several members of the hospital staff, both in the emergency department and on the medicine service, who had advised that I was a good person and had had no difficulty with any staff members. He also indicated that Dr. H was a star resident who was doing important research at the hospital. At the meeting, Dr. H passed me a letter in which he apologized for upsetting me, but indicated that I had misconstrued the situation. The meeting lasted 30 minutes, after which I left the room. Ms. Darlington, what strikes you, just one or two issues around equity broadly in this case?
Sure. Thanks so much for having me here, Dr. D. I'm very quickly, I think the first thing that strikes me is that this is a Hispanic patient that has high risk. And that high risk was not factored into the decision-making process with the resident in this scenario. I think also is that this example is just fraught with a number of other areas that I could go on, but I'll speak to sort of how the resident actually physically touched the attending physician. So two things that come to mind for sure is the legality of this resident's behavior and what that may mean for the hospital if any of those incidents were explored in a more deeper approach or way.
And with respect to inclusion, what issues do you see?
Okay. From an inclusion standpoint, I think that when information was shared about the discussion about the actual attending physician, there wasn't the same level of inclusive engagement to sort of talk about the various experiences with the attending physician versus that of the resident. I think also another area of inclusion is cultural competency. Sounds like it would be a key factor as it pertained to the fellow or the resident, and that really potentially not understanding the risk factors associated with the Latino patient.
From a viewpoint of Dr. JD, looking at this chart of equity versus inclusion, this plot, the 2x2 matrix, where would you place Dr. JD's experience? What is Dr. JD experiencing? What type of culture?
I would say distressed, as well as I'm a little hesitant to say anxious because I think that was one of the words that was used to describe her, and I don't necessarily know if that was a fair representation of her, but I think certainly distressed for sure. But psychologically unsafe culture as well as toxic culture certainly represent the culture in which she had to practice.
Are there any other comments just generally you would make about this case as you listen to this case?
Well, as I mentioned earlier, I really think it's fraught with a lot of different issues going on within that organization. I do think that training would be helpful for the individuals that's a part of this, and more so the resident. I think that there's a lost opportunity for this individual if he's not given some training, but I think also some just exposure. He may not be aware of some of the lack of information that he is experiencing in this scenario. And he also may not recognize his behavior and how that comes across that he may not have been exposed to different patient populations. And based upon the onset of and description of this story, this is a hospital that serves diverse patient community, both from a racial as well as a socioeconomic standpoint. So I really think that there's a missed opportunity for training, and that missed opportunity could negatively impact the institution or the hospital down the road if that type of behavior persists or is allowed to go on without any type of disruption.
Thank you, Ms. Darlington. Really appreciate those comments. Now for our audience, here is your homework. What we would like you to do is to send us your comments with respect to issues of equity, issues of inclusion that you've seen in this case, and importantly, what do you think would be a better problem to solve for Dr. JD to address her concern? And remember, a better problem to solve is a problem which not only would address Dr. JD's concern, but would also be beneficial to many others in that environment. And remember some of the comments that Ms. Darlington's commented on, some of the things that she commented on as you think about all of the individuals in the environment. Thank you again, Ms. Darlington, and I appreciate your taking us through our premier case discussion.
Thank you, Dr. D. My pleasure.